Cardiff situation is very much similar as well. So they've got 193 patients, is it, on the pathway now. The graphs are slightly different. So the reds are the 36 weeks at the bottom here. Only a handful of patients waiting more than 36 weeks on the RTT pathway for surgery. Bulk are again, in green, 26 to 35, or the yellow bits here. And these are the patients who may be waiting even for outpatient's appointment. And that feature has been consistent, I would say, for 2.5 years or so. Nick is here, because I've seen this data through the WISC performance meetings for about 2.5 years or so. But the patient's journey is a bit more complex than just coming to the surgeon and having an operation, because there are a whole heap of investigations up front. And I think that is where all those long waits come from. And this is just the ABM data. I don't have the Cardiff's data. Most of the diagnostics now are within the 8-week category as required by the targets, but the MR and the CT scan waits are still quite long in ABM, and that may dictate some of the long waiters that we're still seeing towards the longer ends of the RTT pathway. But efforts being made to try to reduce those two aspects of cardiology diagnostics. I think I'll skip this slide. That doesn't really say much. So that's your outpatients weight in terms of where we are compared to where we used to be 2, 3, 4 years ago. If you saw that data 3 or 4 years ago, you'd have somewhere around 400 to 450 patients waiting with long tails going out to 52 weeks. So that's no longer the case, either in Swansea or Cardiff. The in-house patients, if I'm honest with you, to get the data for how long patients wait is very difficult, because the processes underneath it are not watertight. So rather than give you bad data, I will share with you what the processes are and what is happening in terms of number of patients who are referred. So this is the Cardiff data. So they have roughly around 300 to 350 patients which are referred for inpatient surgery each year. And that's a consistent feature over the last 5 years or so. And if I represent the data in a slightly graphical form, so there are some variations month to month, but on average you'll have about 27 patients who are referred for urgent inpatient surgery. The activity is hovering around the 14 patients, so roughly speaking, most patients will be waiting for about 2 weeks, if you just translate the two together. Swansea's data is, so this is from referral to surgery, not the in-hospital length of stay. Swansea's data is not much different. I've presented the Swansea data in a slightly different format in light of what Paul was discussing this morning. So the Swansea data, we have a weekly data sheet which is collected, and what I presented for you is a 10-week sample over 2017-2018 period. And what each of these bars represent is that on the 19th of April 2017 and subsequently in 10 sample weeks, how many patients were waiting in the hospital for an operation. And as you see, the number varies from as little as 7 to 8 to 20 plus patients waiting for an operation. The different color bars represents patients which are fit, which are green, awaiting review of other investigations, optimization, etc., which are amber, and the red is the patients who are unfit. So a lot of the time, patients may be waiting in the hospital, but they're not really fit for an operation. So I think it's unfair to lumber the whole 20 plus days of in-hospital waiting to a surgical wait. And if I show you the next slide, you will see what I mean. So this is how long they wait in the hospital. So each of the weeks now has got how long the average wait has been in the hospital. As you see, I said to you just over 2 weeks. Now I want you to concentrate on the third column and the fifth column here. So the October column and the June column. So the October column sort of is the shortest waiting list, or one of the shorter waiting lists, and the June column is the longest waiting with an average wait of 29 days, it says there, okay? Now if I take you back to the original data, if you look at the June column, the reds and the ambers are the lowest numbers of the entire thing. So if you've got a lot of fit patients, people don't wait very long. And the June column is exactly the opposite way around. You've got very few patients, so they wait a long time to get them optimized before they have an operation. The October column has got a big chunk of a green proportion of patients, so your mean waits are very short. And somehow or other, we need to be able to process this group of patients into the greens before we can reliably measure how long patients are waiting in an operation. And that's, a wider discussion, because patients are not just being referred from tertiary centers, they come from across the network. So as things stand today, I've given you a snapshot from Swansea for today. If you were referred for an operation in Swansea, there are about 8 to 10 patients who are waiting in a hospital who have got a date for an operation, but they are waiting. We haven't put them on the list, but they've got a date over the next 5 to 7 days. The reds are 0. There is a small proportion of amber group of patients, but there are 16, 17 patients waiting in Swansea or Southwest Network for an operation at present. And Cardiff numbers will reflect exactly what I've shown you, the data around the 27 patients waiting. This, for some of you who will be familiar with this report, Get It Right First Time report, the GERF report, which was commissioned by NHS England. It's got a number of recommendations about how inpatient cardiac surgery should be managed, recognizing the fact that inpatient cardiac surgery is between 45 and 50% of, especially our work in England, it's about 30%. And the recommendations in terms of resource utilization is to try to separate out the inpatient pathway versus the elective pathway and have ring-fenced resources in terms of ITU beds, theater times to process the two together rather than having competing demands on the theater time as well as the inpatient beds. It has been accepted by the College of Surgeons, it's been accepted by the Society of Cardiothoracic Surgeons. So I think somehow or other we need to take some of the recommendations on board. And what specifically I think with regards to inpatient surgery I think is important is that the patient should be placed, once they're ready, into the green zone onto the first list which is available for them. But it requires wider engagement across the network and the surgical teams. Now I'll move on to the capacity issues finally. So with regards to operationally and capacity-wise, Cardiff and Swansea both run 2 theaters Monday to Friday. So back of the envelope calculation tells you that you should be able to do somewhere around 20 operations, assuming you get through 2 operations on each list. Cardiff run 3 lists on a Thursday, but otherwise 2 lists there as well. But if you try to, some of you will have seen this sort of data presentation before. So the green bar represents your maximum capacity theoretically. The blue bar represents the planned cancellations for whatever reasons, and the red bar represents actually what was completed. So you may have theater canceled because of states issues, you may have because of staffing issues, and even from that, the actual cases that you complete are below that. And this is pretty typical of every unit around the country. The gaps between the two is your ability to performance manage each of the units. Nationally, the sort of cancellation rates vary from high single figures, which are 8 to 10% for places like Papworth, to other units, which your cancellation rates can go as high as 30, 40%, the gap between the red and the green. We come to the reasons for cancellations in a second. This is the Swansea's data for recent paths. I didn't put the bar, but you could draw a bar for 20 for Swansea at the top. And as you see, even our ability is exactly the same. You can never. And the two necessarily don't match. If you plan to do less cases and get them completed, that is better than having a bar up here and not actually doing them. So somehow or other, planning to do more doesn't necessarily translate into doing more. It's better to plan to do less and get them done. And that sort of planned against delivered activity is a very strong measure of the team's performance and the use of resources within the entire group. But we don't seem to be able to get the two to track together. And maybe Nick and I'll share the data with you later. So now we need to look at why we never seem to be able to get to the top line. And here are the data for Swansea for cancellation of cases for the last financial year. So emergencies taking priority, that may mean overnight emergencies or emergencies during the day. There are things about cases overrunning. There are a number of those, as you can see. Theater staff and availability, whether it's either medical staff or other support staff, scrub-wise, perfusion-wise, etc. The bed capacity is rarely an issue in Swansea since we had an ITU expansion 2 years ago, so that has largely been taken out of the equation. But emergencies and the theatre cases overrunning, they seem to be predominant now. And Cardiff's data, I've got the data from a year ago, I haven't got the latest data, is something similar as well. So workforce issues and emergencies seem to predominate here as well in Cardiff. So that hopefully gives you a flavor for what the states type of issue and workforce type of issue lead to cancellation of cases in both the places. So I'll try to sort of get the thing together into a summary and closure now. So I put them in green, amber, and red. So I think, quality of surgery remains excellent in both of the units, both at a unit-specific and at an operator-specific level. So that I've given that a green. Access times for elective surgery continues to be an improving picture, and that I think for the wider network and our commissioners must be a positive thing given where we've been recently, 2, 3, 4 years ago. But there's more work to be done there. The inpatient urgent surgery remains a significant proportion of our work, making up to about half of our workload. There is increasingly complex cases which are being done in South Wales compared to the national figure, and that presents a significant operational challenge. And what I mean by that you may theoretically have a capacity to do 2 cases, but you're never going to get through because the cases are rather long. Inpatient wait for surgery, elective, urgent in-house operations. We really have a very poor handle on the current position, and I think we should try to look to take up some of the national recommendations that have been made by the Get It Right First Time report for inpatient surgery as well as high-risk surgery that I've alluded to with those blood plots that I showed you before, so that patients are reassured that they will get the right treatment and the right advice. Okay, I think I'll stop there if that's okay.
That's my question. Stand there. Don't go away. Get it. Although I couldn't read the font, I'm afraid, for some of those, sorry. But it's very reassuring to see the excellent outcome data and comparison. We appreciate how closely monitored you are. The 2 questions really, one in relation to the outpatient work and how confident you are now in West Wales and perhaps in Commons and South East Wales that the referrals that you have, that you're counting from the original referral made by the GP rather than from when the patient is referred to the tertiary centre, because we know that's been historically an issue, and there's still a feeling in the DGHs which you may be able to reassure me, but I know from my own cases that we're seeing it's still 36 weeks. And the second relates to the in-house work, and you touched on this, but I think it's appalling that we're not measuring that properly. I appreciate it's complex to do so, but we've just spent a few hours talking about changes in days for transferring patients with NSTEMI and managing them appropriately. We're talking about weeks and possibly months for patients who require in-house surgery, and this really needs to be looked at.
I agree with you, Gathan. I think to go back to your first question, I don't think, if I'm honest with you, I can reassure you that the RTT is being appropriately measured because the IT systems across health boards are still not talking. And whether patients are being brought across on what we call closed pathways as opposed to open pathways, I personally haven't got reassurance as well, because if you see the letters, the communication, it doesn't sort of reflect into the numbers which get reported by the IT system. So I think that requires a little bit of discussion with regards to the pathway is your first question. Second question, I think once the patients have seen a surgeon, I can tell you that in Morrison at the moment, the waiting times for an operation after seeing either myself or any of my colleagues is between 12 to 16 weeks. Nobody's waiting more than that. Maximum, okay? But it's still long, okay? In patients, the data I've sort of showed it to you as it is. There are about 27 patients which are referred in Cardiff for an operation every month. And if you do a simple back of the envelope job that you get through about 50 to 60 cases a month, then they're going to wait 2 weeks on average, because you never do a week of elective and a week of cold activity. It just doesn't happen. So the waits are far from, but I think the inpatient reporting of the data is flawed as well, because at the moment, if the inpatient episodes are counted from when the patients came in, then they have an angiogram, then there's a delay for the referral, then there's a delay for fitness. So I think we have to try to separate those out. Now, we're trying to do that with the sort of a red, amber, green type of an approach. But I think we need to get to an electronic referral base, and we have designed up a electronic referral system, which is what we want to get up to, and that way we'll have much better handle, because we don't actually know the size of the problem. But there clearly is an issue in terms of getting to the theatre once you're ready.
Yeah, thanks, Pankaj. I'm pretty sure that once a patient gets to theatre, they do have a very good outcome. However, the way you present the data is, don't take it personally, but the way you present the data is very difficult to know where the delays lie. Now, I appreciate you have to say the RTT is from day of initial referral by GP to the time they get surgery. But from your side, we fought for a long time in Welsh Government to get component weights accepted. I still think it's the way to go, because we could then say for the cardiology end of the pathway, it's 16 weeks tops, and you've got 10 weeks to do your intervention. So what you said, from the time they see you at the moment, you're outside that 10 weeks, you're 12 to 16. So it would be, it's clarity really, it's about working out where the delay lies and which part of the pathway. So it's just a plea, can you do that?
Yeah, sure. I think, we can look to present the data in that format, but I think the problem that the pathway team are facing is that it is very difficult to work out whether the patients are coming into the surgical thing with the diagnostics completed. A significant chunk of our patients are coming in without the diagnostic work being done. And then they will apply the rules as they state, that thou shalt not be at 2 open points in the same pathway.
That's fine. And that takes me straight to my next bit, because the get right first time recommendations. Yeah. Can we look to apply those recommendations to practice in Wales?
We're trying.
Because it answers a lot of those
issues. It does. I think what would be the best way forward is that if we try to get a handle of who is actually waiting for an operation. And as I think we had a long conversation about the pathways for referring inpatient for surgery. The pathways are slightly different in the 2 units. In Morriston, we have a surgeon of the week, as all of you know, who refer to Morriston. In Cardiff, it's slightly different as well. But despite the pathways trying to be unified at a single point of entry, if you asked me today how many patients are waiting for an operation, I honestly couldn't put my hand on my heart and say, John, this is how many patients are waiting. And I think we need to move beyond that. I think we need to get to an electronic position where you can track the patients who are referred and their process and what the delays are. So unless we understand what the delays are, we were talking about unlocking the pathways, in terms of resources in bed days which are locked as an inpatient wait for surgery. So I think we need to understand where that delay is, i.e. how we make those reds and ambers into green at the earliest opportunity.
Thanks very much, Pankaj. I'm going to stay. I'm going to stay with the inpatient surgery theme. I'm glad to hear you mention getting it right first time, because we've been in conversations with GIRFT about getting them involved here as well. And I think there definitely are lessons there that we can learn. But just to ask you what your feel is about the high proportion in Wales. Does this reflect the population of patients, or does it reflect historical patterns that evolved because of long waiting times, perhaps? Is there an objective criteria that we're applying for who gets referred as an urgent case or not? And so just following on from that one, I suppose, to the slide you showed about the number of patients who are unfit, to what extent are those patients, would they have been known to be unfit at the time of being referred on, and could that fitness have been sorted out earlier, or is that just fortuitous things like people catching colds beforehand?
So to pick up your first the point about do all the patients who get referred for inpatient surgery need to wait in the hospital? The answer is no, in my view, and a lot of the other view around the country when we talk to the colleagues from Liverpool. But, you know, for the referring team as well as the surgeon, you need to have reassurance that if you're going to send somebody home, you've got sort of a pretty much a guaranteed ability to be able to bring them in within the 2 to 4 week window. Our practice as a result of the extremely long RTT times over the years has been that if somebody comes in with an acute decompensation, whether it's non-STEMI, heart failure, syncope, whatever, that they'll be kept in the hospital till they've had an operation. Because we've never had the confidence that, you know, we can send them home and then bring them back in. So as the RTT has come down, and, you know, if we can get to a component wait times even lower than where we are at present, I think there will be opportunity to send a number of these patients home who could be given a date in 2 weeks' time, 3 weeks' time, 4 weeks, as is clinically appropriate. I don't think all of them do need to stay. The acute coronary work is obviously very different because the evidence base there will tell you that they need to stay and be fixed on that admission. But I think a lot of the valve patients, the heart failure patients, are being admitted and then they sit in the hospital beds for a long time waiting for a date for operation. I think that's the group we should concentrate on. I think the ACS patients, the non-STEMI patients, they do need to stay, and I think probably we need to sort out our pathways to get them to theatre at the earliest opportunity. You see, for the ACS pathway, the dual antiplatelet therapy, you know, you're going to lose 5 to 7 days anyway till they're fit for an operation. But I think at the moment, we're waiting even longer than that. The other fitness for surgery, the other common causes for delay is optimization of heart failure for the heart failure patient, and that can take some time. Being assessed and having the appropriate dental review for valve patients. Delays in terms of getting them fit. And sometimes the other adjunct investigation, whether it's anemia or whether it's stroke or whether it's chest. Those are the 3 main reasons, I think.
Adrian.
Sorry, I want to reiterate the point of Gethin and the message back to the commissioners. We had the report from the DSU last year and a concern about RTT times. I know that hasn't been addressed because I had a meeting with our performance manager only 2 months ago to say we've got a problem with PSDs. We haven't given our patients start dates to Morriston. So I know we haven't done it for surgery. I know, because I've looked at it, that every patient on my elective waiting list for elective PCI, their start date for which their breech RTT is measured is after the angiogram that determined they needed an angioplasty. So I know my own elective patient's RTT is being calculated from not an RTT. Comes back to the components. The component weight focuses the mind. It has with the 8-week wait for tests. If each component weight focuses the mind, the RTT takes care of itself. And as a patient, I wouldn't be complaining about my RTT. I care about when you tell me I need an operation, how long I've got to wait for my operation, how long do I wait for my outpatient when I'm told by my GP I need an outpatient appointment. I don't start my journey saying how long's my RTT going to be.
I agree with you totally, Adrian, totally agree with you.
Can I just add, sorry to, I mean, I know from Welsh Government though, Sam, I'm sorry to put you on the spot, but we did work with Welsh Government as the Cardiovascular Society for 4 years on component weights. And I've never understood, and we did meet with Simon Dean and Chris Jones to discuss adopting component weights, and it was turned down. But you can see the problem that we're talking about interventions. So you have a diagnostic pathway that comes to a point of decision for an intervention. Could be cardiac surgery, could be stents, could be devices. Can we please move towards that? Because we'd be able to measure performance much more accurately. And we don't get into this issue then for the treatment end of the pathway. When did it start? We can still measure when it started, but it's not critical to your performance.
I think, as Adrian says, I think for a patient, you know, once the decision is made that I'm going to have an angioplasty or I'm going to have surgery or whatever, he wants to know, how long am I going to wait, doctor? You know, he really isn't interested, you know, upfront what happened when the GP referred and so on. So I do think that component weight is the way to go, you know, and I don't quite understand what the big resistance is, you know, if the clinical groups across the network are agreed on it.
And also
and how do we move it forward then?
The component weight, if there was pressure on the component weight, particularly, I know from my own point of view, the problem is outpatient waiting times. Is getting those patients, is trying to identify the ones and try and push them quickly who are going to need intervention. We can't tell. It's very difficult to do that. So we've got long waits, and so you've already ruined your waiting times for your diagnosis. Even if your diagnosis is like for angiography, we've got quite short wait, but by the time they're seeing outpatients, you've blown it. So the question is how you do that and how you manage that. But we need to have that figure so that you can put pressure then on the individual health boards, on the individual hospitals, to actually deal with the problems as they are. Your problems might be different from my problems, different from John's problems, whatever it may be. So you want to make a comment at the back?
Sorry, I'm Andrea Richards, I'm the cardiac planner at WISC. It's just in relation to the comments around the DU action plan. WISC commissioned that back probably just over about 18 months ago now, and there's been various pieces of work done along the pathway at each of the health boards. And more recently, Welsh Government colleagues wrote out to all the health boards to ask for confirmation and assurance that all the pieces of work that had been done that were in that action plan had been completed. And it is my understanding that every health board responded to say that work had been done. But I think from our point of view, when we're monitoring performance with each of the centres, there is still some evidence to say that that's not really happened. And I'm sure both the regional centres could probably confirm some of that. But I think the work was done and the health boards have confirmed that that work has been completed.
I mean, I think some of it does happen to pay lip service to any targets and things like that, and I think they may have done the work, but actually putting the work in to actually make a difference to patients, I don't think is happening. Geraint, do you want to?
Yeah, just thinking in terms of component weights, I think there's a big trick to be played by doing all these things in parallel. We've traditionally done it in series, where you see a cardiologist, you have a DOE, you have an angiogram, you see a surgeon, then you have an operation. But if I get a high quality referral for somebody with severe MR, I put them on a waiting list to be seen in my clinic, a waiting list for a TOE, a waiting list for an angiogram, and refer them to the surgeon before I've seen them. And then by the time they've had all those things done, everything comes ready at the same time rather than waiting for them all in parallel. The RTG girls really don't know what to do with that.
But then
it works.
But then you start doing more diagnostics while patients. So the GP, I mean, just for instance, again, it's anecdotal. GP says, oh, this patient's got a terrible murmur, so you try and push through an echo while they're waiting to see outpatients. And sometimes, if I've had the echo, it doesn't show very much, but okay, it's all well and good. But sometimes patients haven't had the echo because we've got quite long waits for echo as well. So you've seen me in the meantime. I know I'm going a bit deaf, but I couldn't hear a murmur. So they haven't really got much of a murmur anyway. So if you then push those through to get them in quickly TOE, whatever it is, you may be wasting other resources for patients.
It depends on a high quality initial referral. Most of the ones I get would have already had a transthoracic echo, so they're not waiting for that.
The whole spectrum of things from a very good referral to absolute rubbish referral is true.
I mean, if I can just make a comment, there are two ways one can look at this, for those of you who are interested, please, read, there's a very fascinating article written by one of the journalists, I think he writes for Times or Telegraph, doesn't really matter, in the BMJ about 3 years ago about the impact of diagnostic delays on definitive therapeutic. And those of you who haven't read it, I would just urge you to read it to see what a patient's perspective is of all of this. If somebody's got a murmur who's been referred by a GP, in my view as a surgeon, and I'm just a jobbing surgeon, he needs an echo. It doesn't matter which other specialty. If he's got echo criteria of severe valvular disease, that's what gets the ball rolling for him. If he's waiting 20 weeks to see a cardiologist, another 10 weeks to have an angiogram, another 10 weeks for a TOE, we're not serving that patient very well. And I think it's very difficult to take a different view from that. And that is a plea for more diagnostics, which exactly what Phil said, and I think it's very difficult to take a different view from that approach, really, to be honest with you. Nobody with a moderate valvular disease is going to require any intervention. Yeah, they'll require optimization of treatment in terms of tablets and so on and so forth. But if we're talking about the RTT for an intervention, whether it is transcatheter intervention, surgical intervention, PCI intervention, that you need to establish a diagnosis before we can get further down the pathway. And I don't know, how we move that further forwards, really.
Well, diagnosis are a huge thing, and we obviously talk about that. It's something that impacts on us all, waits for that. And you say you could do those things very quickly and easy if you increase the amount of diagnostic echo, for instance. But you still have to have a cardiologist who's going to put things together. I mean, the other thing that happens, certainly with me, is that because we've got so many patients pressuring follow-up services for outpatients, we've got patients who've got severe AS who then wait 18 months to come back and see me when I wanted to see them in 6 months. And all manner of catastrophes can happen at that time. And that's a problem for you, it's a problem for the patient, and certainly, it makes life very difficult. You've got somebody if you operated on a year ago, had a good ventricle, and now 18 months later, you've got a bad ventricle. It makes a huge difference. Peter, you want to...
No, I just wanted to go back to the patient start date, and certainly in Cardiff and Vale, we have not paid lip service to trying to get that right. In fact, I'm concerned that some of the members of the management team are spending so many hours trying to sort out patient start dates and trying to clarify it. We need a better system, but on some occasions, some of the more junior members of the director management team are spending 20 hours a week trying to sort this out. Going back to the source, clarifying it. There's still confusion around when patients have been coming a few times to outpatients and then convert to being referred for an interventional procedure in a tertiary centre. Sometimes we get the patient's start date as the GP referral date, sometimes we get when the cardiologist makes the decision. But for a manager to try and clarify that, and it takes an enormous amount of time. I think the solution to it is moving to electronic referral, and I think we need to move as quickly as we can to that. But the problem isn't paying lip service to it in the tertiary centres. The problem is the 10s and 20 and 30 hours a week that director management people are doing trying to get it right, when they should be doing things to improve the services for the patients.
All sorts of things are missed, and patients are still, their clock's still ticking. In fact, what's happened, they've had their investigation, maybe their tape, whatever it is, you decide there's nothing much wrong with it, or echo is not too bad. And you write back to the GP, tell the patient everything's fine, we'll see you in a year's time, maybe. But their clock's still ticking, they're still on their RTT's going up and up. Because that information, because I've done it, it's not gone through the outpatient systems, whatever it may be. So it's just joining up these figures as well. So, but also to know where we are getting it wrong, but also know when we might be getting it more right. Question here.
Yeah, just to sort of re-emphasise what Peter has just said, being a part of the management team that's embroiled in that RTT management process, certainly in Cardiff and Vale, there is a quite robust process now where there's a kickback to the other health boards to ensure that any patients that are referred in on a cardiology pathway or a cardiac surgery pathway, that we have the accurate pathway start date recorded. The implications of that now is what we've seen in Cardiff is we've been flooded with patients that are on a 26+ week wait, and we've inherited that problem in Cardiff. So actually, our RTT position in Cardiff has deteriorated significantly, both in cardiology and in cardiac surgery. So just to reassure the room that we go back to the management teams in our referring health boards for any patient where we haven't received a pathway start date, and we do not put them on the pathway until we get that date recorded accurately. So that's just to reassure the room that it is happening in Cardiff.
But I think just to come back to that point, I think John's point is very valid, actually. I think we do need to get to a component weight, because although you may validate it, and I'm sure it's validated in Swansea, Michelle and Hannah will tell me at the back, but still it's how that pathway has been managed up front. If the RTT pathway, we start counting from GP referral to cardiology outpatients, there are scopes to stop the clock, and there are all these various, I'm not an RTT sort of a clock managing expert, but when you talk to the team who manage the RTT clocks, it's actually very complex. The book is about this thick for those of you who are interested, and it's not fit for purpose, in my view, for interventional cardiology or cardiac surgery. It may suit orthopedics, it may suit dermatology, but it just isn't fit where, all the diagnostics sits within the umbrella of the single service, largely speaking.
Nigel, yeah.
Yeah, can I just reiterate that point? Actually, I was just about to say the RTT book has just been rewritten, but it's still frankly opaque. And we've had a situation locally where we're getting quite tight about this, where our management team will tell us a start date, and I disagree. And I think the people that actually understand the patient journey and what a legitimate start and stop date is are the clinicians, and we somehow be it electronic, have to have more oversight of this, I think, as a clinician responsible for the patient. I mean, one example, you know, a patient I'd listed for angiography and started a therapy for angina, nitrates, that was perceived, according to the rule book, as you can stop the clock.
Yeah.
You know, madness, isn't it? Yeah. It's a treatment, you know, but it isn't. The patient's waiting an angiogram because I'm concerned they've got serious disease. So I think we have to go back to that rule book. The answer, of course, would be you wouldn't need that if you had component weights, but I think in the interim we need to simplify that and have much more local control, I think, and guidance over that from a clinical point of view.
John?
Just a comment on going back to one thing that did work with all the discussion about component weights. We did get agreement from Welsh Government that the diagnostic test would have an 8-week target, all cardiac diagnostics. And I think there's been an improvement in performance because the health boards are mandated to report 8 weeks. So
I think the will is there and the engagement is there. You can make some progress with it. So I think the problem, you know, I mean, we see the tip of the iceberg in terms of cardiac surgery. There's a whole heap of things which is coming underneath. And it is how the process is being managed in terms of the clocks being switched on and switched off. And I think we need to get to the component weights.
So that's the other question, isn't it? Because the biggest burden you've got is 50% of your work is being done rather than 25, 30%, you say, in England, whatever. Why have we got such a high proportion of patients with emergencies? It's because the weights...
Yeah, I meant to comment on that. When you look at your figures, it strikes me that your complex operations are much higher than the rest of the UK. We've had this discussion before about the threshold for accepting patients for cardiac surgery. And it comes to sharp focus when we do the outsourcing. And we'll send patients to other hospitals in England and they get sent straight back saying, no, we're not doing that. When you're trying to do 2 operations in a list and you put something complex on, you end up doing 1. Yeah. It's tough, but we're going to have to start seriously thinking about who we're operating on, what age are they, what are their comorbidities, what's their outcome likely to be. You can call it rationing, but it's what the rest of the UK do. And I know the business model is different in England, and that probably drives some of the practice, but we are, I think, an outlier. And that, I think, is something we need to look at and consider whether it's the right thing to be doing.
Well, David,
it's food for thought, yes.
We had a conversation yesterday about really are we actually serving our patients properly? Are we using our resources, which, let's be honest, as a finite resource, are we using them most appropriately? I mean, the Griffiths thing is partly that, but we need to look at that. So, yeah, well, thanks very much.
No problem.
Speaking the far in lines for an hour, so that's good.
That's okay.
So now moving on to North Wales, and Paul Mody's going to talk to us about cardiac surgery in Liverpool Heart and Chest Hospital.
Leave that there, shall I?
Can you all hear? Yep, we can't see you, but we can hear you.
I'll leave that there.
Okay, can you hear me? Starting on the Eurovision Song Contest. Okay, I'll carry on the assumption that you can hear me. That's my slides.
to explain what we're going to look at. I'm just about to do that if you give me a chance. The middle line is the 50th centile or the median. And then going above that, we've got the 75th and 95th centile. And then below the bottom of the chart is the 25th and 5th centile. And the mean is the blue dot. This shows our logistic Euroscore for patients over the last 5 years in Liverpool. And that seems pretty static with a median of around about 4 to 5. Moving on to our clinical results, if we just concentrate on the all patients column to start with, and we can see that for all 421 patients from Wales, the mortality was 3.6% with a stroke rate of 1.2%. Hemofiltration was needed in 1.7% of patients. There were no deep sternal wound infections, which I think is a good achievement. Reoperation for bleeding, 5% of patients. Then the median stay on intensive care was 2 days and hospital stay of 7 days. Just looking at the middle column that I've shaded in a slightly lighter colour, just to show our results for isolated coronary surgery in the middle and isolated valve surgery under that. So in 105 cases for isolated coronary surgery, and as I said before, probably 45 to 50% of those will be off pump. No mortality, 1 stroke, no wound infections, no renal failure requiring hemofiltration, 3.8% bleeding rate needing reoperation, 2 days on the intensive care median, and a median of 5 days in hospital. Clearly, when you look at urgent coronary surgery, the outcomes won't be quite as good as that in fitting with the risk profile of urgent patients. If we look at isolated valve surgery, so this is both mitral and aortic valve, again, also very good results. Only 1 death in a year, 1.1% mortality. No strokes, no renal failure requiring hemofiltration, no sternal wound infections, 3% reoperation for bleeding, 2 days on ICU, and 7 days in hospital. Final slide. The majority of patients, over 80%, are discharged home, and just over 10% will either be transferred back to Wrexham, Glenclwyd or Bangor. Thank you for your attention.
Thanks very much, Ben. Questions? Comments?
Once they had a problem with capacity, they could. The reaction, more so.
Yeah, I think it's been effective though. Okay.
Thank you, Peter. I think that, Paul, you know, I mean, what are your reasons for cancellation? Teams sort of tend to be either states-related issues or workforce-related issues, not necessarily sort of medical workforce, but one of the biggest challenges we face in this last half, you know, which is a national issue. But maybe you want to comment about sort of Liverpool's market and so on, about what your reasons are for cancellations.
The very beginning of your question broke up. I didn't hear that. Would you mind repeating it?
The comment and the question was that
Okay, I think I've understood the question. I'll answer what I think you've asked. In terms of the reason for cancellation, it's been a combination of emergency surgeries taking priority the night before, which really is just the nature of the beast with heart surgery, which then impacts on the following day activity, both in terms of enough perfusionists, anaesthetists, or beds on the intensive care unit. We have had an ongoing issue with the anaesthetic workforce, and that we've had a number of senior anaesthetists retire in the last couple of years. Two of our very senior anaesthetists have retired, and we have been running a little bit under on complement of anaesthetists, which also has affected the availability for anaesthetic staff the following day if they're up the previous night with a poorly patient. I think that was the question. I didn't hear that. That's not been much of an issue for us, to be honest, in terms of scrub staff. I mean, in fact, I can't think of a single case where that's been a problem. It's usually, availability of usually an anaesthetist or a perfusionist, or an appropriate surgeon for one of the specialist cases. For example, an aortic case. If the aortic team have been up the night before with a dissection, for example.
Peter says more surgeons.
Yeah, well, I think it's multifactorial. I think in terms of, I must apologise because the line's quite bad. So I think the question is, how can we reduce the cancellations, which I think is what you're asking. In terms of the anaesthetic issues, we're dealing with that, and that will be hopefully solved within the next year as we recruit more anaesthetists. In terms of emergency, that will then reduce the effect of emergency surgery having impact on the following day. So I think it probably needs a multi-pronged approach, because I don't think it's just one specific factor. If I could, in terms of if we cancel, for example, for the sake of if someone's up during the night and the list has to go down the following day, the priority we have in theatre is that we do everything on clinical urgency. So the urgent patients will always take priority over the elective patients on the basis that they're not safe to wait. And patients who've been cancelled before or waiting longer will always take priority over those who've not been waiting long. So we try and do everything on the clinical need of the patient.
Okay, so it's not.
as a referring cardiologist, I just have a slight objection to being completely reliant on a computerised referral system. I firmly believe that the point of referral is when the cardiologist determines that a patient might require inpatient surgery, and they make that referral. And if that referral contains all the necessary information, then I think it's then incumbent upon the recipient of that referral to then start to assume responsibility for it. Now, obviously, if further information is required, then that's fine, and that can be brought and provided. But I don't like the idea of some computerized system where a failure to include a certain piece of information results in a referral being rejected, because I think this will simply lead to more delay and more difficulty. So I don't think we should lose sight of what we're actually trying to achieve here.